So we're finishing up with the diabetic complications, and with the diabetic retinopathy is one of the leading causes of blindness worldwide. It develops more rapidly in type 2 diabetics. It's a progressive process that accompanies the retinal capillary occlusion and ischemia. You have edema in the macular area with fluid accumulation and a thickening of the retina. And a lot of times the treatment is laser treatment, antivascular endothelial growth factor, renin-angiotensin system inhibitors, steroids can also be effective. The microvascular disease is caused by the capillaries thickening in the basement membrane. You can have thrombosis and a periocyte degeneration. And periocytes are cells, contractile cells that wrap around the endothelial cells of veins and capillaries and are part of the basement membrane. We find these cells are degenerate and so add to the thickening of the basement membrane and its response in terms of the capillaries. Hyperglycemia may be present, hypoxia, and ischemia of the cells. And of course, you have nephropathy is the most common cause of end-stage kidney disease in the United States. And progressive changes, you have a thickening again of the basement membrane and enlargement of the glomeruli. You have long albumin in the urine, and treatment is very tight glucose control, ACE inhibitors or angiotensin II receptor blockers, and a very aggressive treatment of hypertension. Then you have the neuropathies, which is the most common complication of diabetes. You have sensory deficits, usually preceding motor involvement. And the distal portions of the neurons are affected initially and then eventually more severely affected, where you have degeneration of the axons and the Schwann cells. And then distally, you have the small nerve fibers causing neuropathic pain and loss of sensation, paresthesias, and then the large nerve fibers, a loss of proprioception, not like the test we used to do where you put the finger up and down and the person cannot detect the positioning of the finger. In macrovascular disease also has a number of complications. There's lesions both in the large and medium-sized arteries as a result of the poor control of glucose. And we have advanced glycation end products, age, attached to their receptors in the walls of the blood vessels. And these end products are substances that have been found in the Alzheimer's, degenerative diseases, diabetes, as well as chronic renal failure. And they speed up oxidative damage to the cells. And these end products have been found attached to receptors in the walls of blood vessels in patients with diabetes. And they promote oxidative stress, inflammation, results to endothelial and vascular smooth muscle dysfunction and hyperlipidemia. Cardio artery disease, coronary artery disease, CAD, is also prevalent in patients with hyperglycemia. It's most common cause of morbidity and mortality, up to 75% of both men and women with diabetes, and increases with the duration but not the severity of the diabetes. It's a consequence of atherosclerosis, hypertension, and puts it at increased risk for thrombosis formation. It can result in an MI, and cardiomyopathy is higher in patients with diabetes. Then you have patients with stroke, which is also a complication, twice as common in those with diabetes, especially type 2, than other persons. And the survival rate after a massive stroke for patients with diabetes is usually shorter than ones without. It's a consequences, again, of hypertension, atherosclerosis, and thrombophlebitis. And the treatment is aggressive management of the blood pressure, control of the glucose, and control of the lipids. Peripheral artery disease also increases in those with diabetes, especially type 2. Along with that, neuropathy, gangrene, and amputation can occur. Atherosclerosis combined with neuropathy can cause ulcers, occlusions, gangrenous changes in the lower extremities that can lead to amputations. More than 60% of non-traumatic amputations in the U.S. are performed on those with diabetes. I remember when I was taking care of patients, there was a lady that I took care of, a young girl that was just stepped on a pin in the carpet and ended up losing her foot as a result. Did not heal because her diabetes was not under control. Like I said, young adult, and as a result lost her foot. And I see that more and more often with the hyperglycemia. They do not heal well. They're prone to infections. And usually referral to a specialist can reduce the amputation rates by at least 85%. Infections are very prominent in people with hyperglycemia. The morbidity and mortality rate from infectious agents increase. And the risk for infection increases for several reasons. They have impaired senses, so they don't know if they're stepping on something or if they have a wound in their foot. Hypoxia, rapid replication of pathogens from the increased glucose. They have the energy to replicate. Decreased blood supply to the part, a suppressed immune system, and delayed wound healing as a result of a high blood sugar. You know, when you keep a piece of bread with sugar on it out, that it starts to grow things. And the same way with the diabetic when they have a wound. We also need to look at alterations of adrenal function, and the adrenal glands are located on either side of the kidney. You have different portions. On the inner portion, it's the medulla. The outer portion is the cortex, which is regulated by the negative feedback loop involving the hypothalamus. The medulla produces epinephrine, norepinephrine during stress, and is responsible for the fight or flight response of the sympathetic nervous system. The cortex has three separate regions that produce different hormones. You have the mineralocorticoids in the outer region, such as aldosterone, that conserves sodium and water. You have the glucocorticoids in the middle portion of the cortex that as cortisol, that increases glucose levels. And then you have the gonatocorticoids in the inner region of the cortex that produces the sex hormones, and androgen and estrogen. Disorders of the adrenal cortex can be hyperfunction or hypofunction. There's no known hypofunction. Usually more hyperfunction is prevalent. The most commonly occurring is Cushing's disease and Cushing's syndrome. Cushing's syndrome is excessive cortisol level regardless of the cause. Cushing's disease is overproduction of the pituitary hormone ACTH by a neoplasm. And you also can be caused by a loss of circadian patterns of ACTH and cortisol secretion, and a lack of ability to increase the ACTH and cortisol in response to stress. And the Cushing-like syndrome can occur, as a result of exogenous administration of glucocorticoid medications. And so the hyperfunction that increases the cortisol can be caused by tumors, congenital defects, damage from the OR, removing some of the organ, radiation, and infections. So the Cushing disease, mostly from too much corticosteroids or tumors that secrete the ACTH or cortisol, or neoplastic syndromes from tumors outside of the endocrine system that secrete substances very similar to the original hormones. With Cushing syndrome, as you know, they have weight gain in the tissue in the trunk, face, and cervical regions, truncal obesity, the moon face, the buffalo hump, sodium and water retention, glucose intolerant and protein wasting, glucose intolerance from insulin resistance, high blood pressure, edema, low potassium, psychoses can occur, protein wasting, renal stones, purple striae on the abdomen, thighs, and breast, delayed wound healing, osteoporosis, low libido, erectile dysfunction, hirsutism, hair growth, bronze or brownish hyperpigmentation of the skin, and thin skin that bruises easily. Usually medication recommends, when you're giving medications, steroids, gradual tapering of the steroids, and we don't want to suddenly discontinue them because the body doesn't have time to initiate its own functions to replace the medication. Radiation and surgery is for the tumors, and to watch for complications. I'm going to, because of time, go into the Addison's disease. And basically, Addison's disease is the adrenal insufficiency or hypocortisolism. It is pretty rare. Mostly a decrease in the cortex hormones as a result of autoimmune mechanisms is the most common cause. HIV virus, fungal infections, meningitis, hemorrhage, and tumors can also cause Addison's disease. It's characterized by inadequate corticosteroids and mineral steroid synthesis and an elevated ACTH. Mainly you've got high potassium, low sodium, and low chloride, low cortisol, and low aldosterone. Fatigue, weakness, hyperpigmentation that's patchy, vertigo, weight loss, depression, salt craving, sluggish movements, low blood pressure, change in heart rate, low blood sugar, and mouth lesions can occur. Usually the treatment is a lifetime glucocorticoid and mineralocorticoid replacement therapy. Increase in dosage usually needs to be done during infection, stress, and trauma, and the patient should wear a medical alert bracelet. They also are put on a 150 milliequivalent sodium per day diet. And we want to talk a little bit about the pheochromocytomas that are caused by tumors derived from the cells of the adrenal medulla. They secrete catecholamines, and so as a result you get hypertension, diaphoresis, tachycardia, palpitations, and severe headache. Usually controlling the blood pressure with alpha and beta adrenergic blockers, and also excision of the tumor with radiation and chemotherapy. I wanted to point out, as a result, two complications with the pheochromocytoma. Like I said, is pretty rare. It can be life-threatening. It can be one or more tumors. You want to watch out for complications, because if they're not treated, you could have hypertensive crisis, stroke, psychosis, seizures can result. At the end of the PowerPoints, you have an endocrine case study with some questions attached. It's a patient with hypertension and type 2 diabetes, and you might want to try to tackle those questions that go along with the case study. So have a good day.